block simulation. 33, same process. Fresh set, read the command first, scan the clues, build fast, lock and move. 20 questions, 30 minutes. Clock starts now. Which sequence of neuromuscular transmission is correct? A physiologist studies how a motor nerve signal triggers skeletal muscle contraction at the neuromuscular junction. Read the command. Which NMJ transmission sequence is correct? Nerve, AP leads to C2+ and leads to ACH. Release leads to nicotinic receptors, leads to Na+, leads to N. Plate depolarization leads to muscle, AP. Acetylcholinesterase degrades ACH. Neuromuscular transmission converts an electrical signal in the motor neuron into a muscle contraction. When the nerve action potential reaches the presynaptic terminal, it opens voltage, gate calcium channels. The Ca2+ influx triggers fusion of synaptic vesicles and release of acetylcholine into the synaptic cleft. ACH diffuses across and binds nicotinic. Acetylcholine receptors ligand-gated cation channels on the motor END plate of the muscle fiber. The correct answer is B. Opening the nicotinic receptors lets Na+ flow in, producing an END plate potential that, if it reaches threshold, fires a muscle. Action potential spreading along the sarcolemma to trigger contraction. The signal is terminated by acetylcholinesterase in the cleft, which hydrolyzes AHA. This pathway is the target of many disorders drugs. Myasthenia, gravis antibodies to the nicotinic receptor. Lambert-Eaton antibodies to the presynaptic K2+ channel. Botulinum toxin blocks ACH release. Current neuromuscular blockers block the receptor, and organophosphates inhibit acetylcholinesterase. The Ca2+ triggered ACH release onto nicotinic receptors, causing in-plate depolarization is correct. What is the type of cardiomyopathy and the dysfunction? A 60-year-old has progressive dyspnea and right-sided heart failure, edema, ascites, elevated JVP. Echo shows normal-sized ventricles with normal ejection fraction, but markedly impaired filling, stiff walls. Biopsy shows amyloid deposition. Read the command. Type of cardiomyopathy and dysfunction. Normal-sized ventricles, normal EF, impaired filling, stiff walls, amyloid, restrictive cardiomyopathy, diastolic dysfunction. This is restrictive cardiomyopathy. The ventricular walls become rigid and non-compliant, often from infiltration, so the ventricle cannot relax and fill properly during diastole, a diastolic dysfunction. Even though the chamber size and ejection fraction are usually normal, preserves systolic function. The high filling pressures back up, producing predominantly right-sided heart failure, elevated jugular venous pressure, hepatomegaly, ascites, and peripheral edema. The correct answer is A. The CA uses are the high-yield part, infiltrative and fibrotic processes, amyloidosis classic, sparkling speckled myocardium, low-voltage ECG, sarcoidosis, hemochromatosis iron, endomyocardial fibrosis, and Loeffler endocarditis eosinophilic, scleroderma, and radiation. It can mimic constrictive pericarditis clinically, both cause diastolic heart failure, but they differ in constrictive pericarditis clinically, both cause diastolic heart failure, but they differ in mechanism and Mengerwale. Contrast the three cardiomyopathies: dilated T, systolic, low EF, hypertrophic diastolic with outflow obstruction, restrictive diastolic with stiff walls and normal EF. The stiff wall, normal, EF, amyloid, infiltrated diastolic failure is restrictive cardiomyopathy. Which statement about the H&P shunt is correct? A biochemistry student studies the pentose phosphate pathway, H&P shunt, and why it matters for red cells and biosynthesis. Read the command. Which H&P shunt statement is correct? Oxidative phase, G6PD, rate limiting leads to NADPH. Non-oxidative leads to ribose. 5-phosphate, NADPH for biosynthesis, glutathione respiratory burst. G6PD deficiency leads to hemolysis. The pentose phosphate pathway, H&P shunt, runs in the cytoplasm and has two phases. The oxidative phase is irreversible and is the right-limiting step catalyzed by GLUtide synthesis, 6-phosphate dehydrogenase G6PD. It generates NADPH2 per glucose, 6-phosphate, and CO2. The non-oxidative phase, reversible via transketolase transaldolase, produces reversible via transketolase transaldolase, produces ribose D-Fios T and alsa, catalyzed by GLCO6-PO-Sal-cis-Fios-conrase G6-PO-Scios-conrase. The correct answer is E. The product to focus on is NADPH, distinct from NADH. It does not make ATP. NADPH powers reductive biosynthesis, fatty acid, and cholesterol synthesis, maintenance of reduced glutathione, the key antioxidant that detoxifies peroxides, especially in red blood cells, respiratory burst in neutrophils defective in chronic granulomatous disease. This is why G6PD deficiency X-linked causes episodic hemolytic anemia under oxidative stress, fava beans, infections, drugs like primaquine dapsone sulfa with Heinz bodies, and bite cells. Because red cells can't regenerate glutathione, the G6PD rate-limited NADPH and ribose producing pathway is correct. Which coronary artery supplies which region, and what does dominance mean? A cardiologist correlates coronary artery anatomy with infarct territory. Read the command. Which coronary supplies which region? Dominance. LAD anterior septum apex, LCX text lateral, RCX text 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 text. Coronary anatomy maps directly onto infarct patterns. The left anterior descending artery LAD from the left coronary supplies the anterior wall of the left ventricle, the anterior 2/3 of the interventricular septum, and the apex. It is the most commonly occluded vessel, anterior anteroseptal, MI, ECG leads V1, V4. The left circumflex artery, LCX, supplies the lateral wall, leads I, AVL, B5, B6. The correct answer is C. The right coronary artery, RCA, supplies the right ventricle, and the inferior wall of the left ventricle leads 2/3 AVF. Dominance refers to which artery gives rise to the posterior descending artery, PDA, which supplies the posterior inferior septum. In 85% of people, the RCA does right dominant. The RCA also typically supplies the SA and AV nodes, so an inferior MI from RCA occlusion can cause bradycardia and AV block. The late anterior LCX lateral, RCA inferior, APDA mapping with dominance defined by the PDA is the answer. What is the diagnosis, and how do the immunofluorescence patterns classify the causes? A 30-year-old develops hematuria, oliguria, and rapidly rising creatinine over days to weeks, acute kidney injury. Biopsy shows crescents in most glomeruli, proliferating cells, fibrin, and Bowman space. Read the command, diagnosis, and if classification. Crescents plus rapid AKI, RPGN, linear, anti-GBM, granular, immune complex, pulsi-immune, INCA. This is rapidly progressive glomerulonephritis, RPGN, also called crescentic GN, the most aggressive nephritic syndrome, causing renal failure over days to WES to WEEs. The defining histology is CREScence in Bowman space, crescent-shaped proliferations of parietal epithelial cells, macrophages, and fibrin that compress the glomerular tuft. It presents with nephritic features, hematuria, RBC CAS, oliguria, rising creatinine. The correct answer is D. The high-yield part is classifying RPGN by the immunofluorescence pattern, which points to the cause. 1 linear, if an anti-GBM antibody disease. Goodpasture syndrome antibodies to the glomerular alveolar basement membrane causing hematuria plus hemoptysis. 2. Granular lumpy bumpy. IF near-knee, complex deposition, post-streptococcal GN, lupus nephritis. 3. PUCI, immune negative, scant ifus akinika. Associated vasculitides, granulomatosis with polyangiitis, CA-ANCA-APR3, and microscopic polyangiitis, eosinophilic GPA, PNKMPO. Treatment is urgent immunosuppression, steroids, cyclophosphamide, plasmapheresis for anti-GBM. The crescentic GN classified by linear granular ifus for anti-GBM. The crescentic GN classified by linear granular. POSI, immune ifus, RPGN. What happens when a person stands and blood pools in the legs? A physiologist studies the baroreceptor reflex. This question targets the response to standing you up, orthostasis, not the basic anatomy. Read the command. Baroreceptor responds to standing. Standing leads to decreased venous return, leads to decreased BP, leads to baroreceptors. Fire less leads to increased sympathetic, decreased vagal leads to increased HR, contractility. Vasoconstriction leads to BP restored. This revisits the baroreceptor reflex from the orthostatic standing angle. The carotid sinus baroreceptors, CNX, and the aortic arch, CNX, are stretch receptors that fire in proportion to arterial pressure. When a person stands up, gravity causes blood to pool in the leg veins, reducing venous, R return, stroke volume, cardiac output, and therefore arterial blood pressure. So the baroreceptors are stretched, LES, and fireless. Correct answer is B. The decreased baroreceptor firing is interpreted by the brainstem nucleus tractus solitarius as low pressure, so it triggers a compensatory response, decreased parasympathetic vagal tone and increased sympathetic outflow. The result is an increased heart rate and contractility plus arteriolar and venous vasoconstriction, raising total peripheral resistance and venous return, which restores blood pressure within a few heartbeats. When this reflex fails autonomic dysfunction, hypovolemia, certain drugs, age, the person develops orthostatic hypotension, a drop in BP on standing with dizziness. The stand leads to less firing, leads to more sympathetic, leads to BP restored. Cascade is the answer. Which statement about tetracyclines is correct? A patient with chlamydial infection is given doxycycline. A teenager's acne is treated with a tetracycline. Read the command. Which tetracycline statement is correct? Bind 30S block amino acid tRNA, bacteriostatic, atypicals, spirochetes, teeth bone, avoid kids' pregnancy, photosensitivity, K ions block absorption. Tetracyclines, doxycycline, minocycline, tetracycline inhibit protein synthesis by binding the 30S ribosomal subunit and blocking the attachment of aminoacyl tRNA to the acceptor site. They are bacteriostatic. Their spectrum is broad and especially strong against ion trace villi. Atypical organisms, CH chlamydia, rickettsia, Rocky Mountain spotted fever, mycoplasma, as well as spirochetes, Lyme, Vibrio, Brucella, anthrax, and community MRSA, doxycycline, minocycline for acne. The correct answer is E. The toxicities are high yield. Tetracyclines deposit in calcifying tissues, causing permanent tooth discoloration and inhibition of bone growth. So they are avoided in children under 8 and in pregnancy, also hepatotoxic in pregnancy. They cause photosensitivity, sunburn, and rarely pseudotumor cerebri or vestibular effects, minocycline. A practical pharmacokinetic point, their absorption is impaired by divalent trivalent cations. So milk of dairy, antacids, calcium, iron, and magnesium chelate them, and reduce absorption take separately. Doxycycline is renally safe, clear, fecally useful in renal failure. The 30S binding atypical covering tetracyclines with tooth photosensitivity, toxicity, and cation chelation is correct. What is the diagnosis? The triad, and a common cause by age. A 70-year-old has exertional syncope, angina, and dyspnea with a harsh crescendo, decrescendo systolic murmur radiating to the carotids, and a soft delayed pulsus parvis et tardis, carotid upstroke. This question targets the clinical aortic stenosis. Read the command. Diagnosis triad caused by age. Crescendo decrescendo, systolic murmur to carotids, parvis et tardis, exertional syncope angina dyspnea, aortic stenosis, ACD triad, calcification old A bicuspid young. This revisits aortic stenosis from the clinical angle. Aortic stenosis produces a harsh crescendo diamond-shaped SY systolic ejection murmur, best heard at the right upper sternal border and radiating to the carotids. As it becomes severe, the carotid upstroke is weak and delayed, pulsus, parvis, ET, tardis, and the murmur peaks later with a soft absent A2. The obstruction to LV outflow causes pressure overload concentric hypertrophy. The correct answer is A. The classic symptom TRAD, which signals severe disease and a poor prognosis without valve replacement, is SAD, exertional syncope, angina, and DYSPNEA, heart failure. The causes vary by AG. In older patients, it is most often degenerative. Senile calcific aortic stenosis. In younger middle-aged patients, suspect a congenitally bicuspid aortic valve which calcifies prematurely, and rheumatic disease is another cause. Note that, unlike most murmurs, AS is softer with Valsalva. Onset of symptoms warrants aortic valve replacement. The carotid radiating systolic murmur with parvus et tardus and the SAD triad is clinical aortic stenosis. Which organism is responsible? A hospitalized patient develops a urinary tract infection, and another develops subacute bacterial endocarditis after a GIGU procedure. Cultures grow gram-positive cocci in chains that grow in 6.5% NaCl and bile esculin. Some isolates are vancomycin resistant. Read the command. Which organism? Gram-positive cocci in chains grows in 6.5% NaCl plus bile esculin. UTI endocarditis after GIGU, vancomycin resistant Enterococcus. This is Enterococcus fecalis and the more resistant E. Facium, gram-positive cocci in chains, bears catalase, negative, and part of normal good flora. They are distinguished in the lab by their hardiness. They grow in bile and hydrolyze esculin, and grow in 6.5% NaCl high salt, features that separate them from the other group D and Viridian streptococci. The correct answer is E. Clinically, enterococci cause urinary tract infections, biliary tract and intra-abdominal infections, and subacut bacterial. Endocarditis, classically following GI or GU instrumentation procedures which release them into the blood. The major reason their high yield is antibiotic resistance, vancomycin-resistant Enterococcus. VRE is an important nosocomial pathogens. Enterococcus RE is an important nosocomial pathogen resistance via D-ALA, DIIE, often requiring linezolid or daptomycin. The bile. Esculin positive, salt-tolerant gram-positive cocci causing UTI and post-procedure endocarditis, including BRE, are Enterococcus. Which statement about thermoregulation is correct? A physiologist studies how the body maintains a constant core temperature, thermoregulation. Read the command. Which thermoregulation statement is correct? Hypothalamus set point, anterior heat loss, sweat vasodilate. Posterior heat conservation, vasoconstrict shiver, fever pyrogens IL-1 met, AC1 PGE2 raise set point. The hypothalamus is the body's thermostat, maintaining core temperature around a SET point. The anterior hypothalamus preoptic area responds to a rise in temperature by activating heat loss mechanisms, cutaneous vasodilation and sweating, and behavioral cooling, HCC, anterior cooling. The posterior hypothalamus responds to cold by activating heat conservation and generation, cutaneous vasoconstriction, shivering and non-shivering thermogenesis, to keep heat in. The correct answer is C. Fever is the high-yield application. It is not a failure of regulation, but a regulated elevation of the SET point. P-rogens, exogenous, like LPS, and endogenous cytokines IL-1, IL-6, TNF induce prostaglandin E2, PGE2, PGE2 in the hypothalamus, which raises the set point. The body then feels cold and shivers, vasoconstricts to reach the new higher temperature chills. Antipyretics, aspirin, NSAIDs, acetaminophen fever is correct. Acetaminophen work by inhibiting cyclooxygenase, lowering PG2 and the set point. Heat stroke, by contrast, overwhelms regulation rather than resetting it. The hypothalamic set point controlled with anterior cooling and posterior, conserving in PGE2. What is the diagnosis, the mechanism, and why is it an emergency? A 14-year-old boy has sudden severe unilateral testicular pain, a high-riding testis with a horizontal lie, an absent cremasteric reflex, and a negative preen sign, no relief with elevation. Read the command, diagnosis, mechanism, why emergency. Adolescent, sudden testicular pain, high riding horizontal, absent cremasteric, negative prehen, testicular torsion, cord twist leads to ischemia, emergency 6 Eshko. This is testicular torsion. The spermatic cord twists on itself, typically because of a congenital bell clapper deformity, inadequate fixation of the testis within the tunica vaginalis, allowing it to rotate freely. The twisting first occludes the lower pressure venous drainage, causing swelling, engorgement, and then the arterial supply, producing testicular ischemia. It classically presents in adolescents with sudden, severe unilateral testicular pain, often with nausea. Correct answer is B. The exam findings and urgency are the high yield points. The testis is often hitch riding with a horizontal lie. The cremasteric reflex is absent on that side, and elevating the testis does not relieve pain, a negative pren shine, which helps distinguish it from epididymitis, where elevation relieves pain. Positive pren, and the cremasteric reflex is preserved. It is a urologic emergency. The testes must be detorsed and fixed orchiopexy, with fixation of both sides within roughly 6 hors to remain viable. Beyond that, infarction occurs. Don't delay for imaging if classic. The bell clapper cord twist causing ischemia with an absent cremasteric reflex is testicular torsion. Which structure is at risk, and what is the classic relationship? During a hysterectomy, the surgeon must avoid injuring a structure that runs beneath the uterine artery near the cervix. Read the command, which structure at risk and the relationship. Ureter passes UND, uterine artery near cervix, water under the bridge, at risk in hysterectomy. The structure at risk is the urete. The classic, heavily tested anatomical relationship is water under the bridge, the ureter carrying water, urine passes beneath the uterine. Artery the bridge, as it approaches the bladder, near the level of the cervix about 1 to 2 cm lateral to it. This crossing point is exactly where the surgeon ligates the uterine artery during a HY hysterectomy, so the ureter can be accidentally clamped, ligated, or cut if not carefully identified. The correct answer is D. This is the most common site of iatrogenic ureteral injury. The ureter course is worth tracing. It travels retroperitoneally, crosses the pelvic rim, anterior to the bifurcation of the common iliac artery, runs along the pelvic sidewall, and then, in females, passes under the uterine artery and over the lateral fornix of the vagina to reach the bladder. In males, the analogous relationship is the ductus deferens crossing over anterior to the ureter, the duct of the deferens, passing anteriorly. Recognizing water under the bridge prevents ureteral injury. The ureter beneath the uterine artery near the cervix is the at-risk structure. How are these anxiety-related disorders classified? A psychiatrist evaluates several patients. One has discrete episodes of intense fear with palpitations, chest tightness, and a fear of dying peaking in minutes. One has 6+ months of excessive, uncontrollable worry about many things with restlessness and insomnia. One has intrusive obsessions relieved by compulsive rituals. Read the command, how the anxiety disorders are classified. Panic disorder, recurrent attacks, GAD, at least 6 more worry, OCD, obsessions, plus compulsions, SSRIs, CBT. These are distinct anxiety-related disorders. Panic disorder is defined by recurrent, unexpected panic attacks or behavior attacks of intense fear, peaking within minutes with somatic symptoms, palpitations, chest pain, dyspnea, sweating, trembling, derealization, fear of dying or going crazy, plus persistent worry about future attacks or behavior change, discrete panic attacks or behavior change, anticipatory about future attacks or behavior change, anticipatory anxiety, sometimes with agoraphobia. Generalized and anxiety disorder GAD is excessive, hard to control, Worry about multiple life domains lasting at least 6 months with restlessness, fatigue, irritability, muscle tension, and sleep disturbance. The correct answer is C. Obsessive compulsive disorder (OCD) features recurrent, intrusive obsessions, unwanted thoughts and/or compulsions, repetitive behaviors, rituals done to reduce the anxiety that are time-consuming and ego. Dystonic, the person recognizes them as excessive, unwanted, distinct from obsessive-compulsive personality disorder, which is egosyntonic. POB is specific phobia, social anxiety disorder involve marked fear. Michos, Hubris is specific phobia. Social anxiety disorder involve marked fear decopter disorders done to reduce the anxiety that are time-consuming and ego-dystonic. The person recognizes them as ego-dystonic. The person recognizes them as excessive object. First-line treatment across these is SSRIs and SNRIs, plus cognitive behavioral therapy, exposure ERP for OCD. Benzodiazepines are used short-term for acute panic. The panic versus GAD versus OCD classification is the answer. Which statement about translation is correct? A biochemistry student studies how the genetic code is read into protein. Translation, and which steps antibiotics target. Read the command. Which translation statement is correct? Cytoplasm ribosomes read 5 leads to 3's initiation, small subunit, AUG, elongation, A site, peptidotransferase, translocation, termination, stop codon, release factors, GTP, antibiotics target 30S by 50S. Translation is the synthesis of protein from mRNA, occurring in the cytoplasm or ribosomes, free or rough, ER bound, reading the mRNA codons in the 5 to 3's direction. It has 3 stages. Initiation, the small ribosomal subunit and the initiator tRNA carrying methionine, formyl in bacteria, assemble at the start codon AUG, then the large subunit joins using initiation factors and GTP. The tRNA anticodon pairs with the mRNA codon, and tRNA carries the matching amino acid. The correct answer is B. Elongation cycles through 3 ribosomal sites. APE, a new amino acyl tRNA, enters the A site E codon. Matched, peptidyl transferase. A ribozyme in the large subunit forms the peptide. Bond and the ribosome translocates. 1 codon consuming GTP. Termination occurs at a stop codon UAA, UAG, UGA, where relegates UAA, UAG, UGA, where release factors free the polypeptide. This machinery is a major ambiotic target in bacteria which have 30S-50S subunits. Aminoglycosides and tetracyclines hit the 30S. Macrolides, clindamycin, chloramphenicol, and linezolid hit the 50S, exploiting the difference from the human 40S-60S ribosome. The cytoplasmic 5 leads to 3's initiation, elongation, termination process is correct. What is the diagnosis, the mechanism, and the progression risk? A 52-year-old obese man with type 2 diabetes and dyslipidemia is found to have elevated transaminases AST-ALT with ALT-AST. He drinks minimal alcohol. Ultrasound shows a fatty liver. Biopsy shows steatosis with some inflammation and ballooning. Read the command. Diagnosis, mechanism, progression. Obese diabetic, fatty liver, ALT-AST, minimal alcohol, NAFLD-NASH, insulin resistance, leads to fibrosis, cirrhosis, HCC. This is non-alcoholic fatty liver disease, NAFLD, the most common cause of chronic liver disease in developed countries. It is the hepatic manifestation of metabolic S syndrome, insulin resistance, obesity, type 2 diabetes, dyslipidemia, drives accumulation of triglyceride fat in hepatocytes, steatosis. By definition, without significant alcohol use. The transaminases are mildly elevated with ALT, greater than AST, the reverse of alcoholic liver disease, where AST-ALT roughly 2001. The correct answer is D. The production is the high yield part. Simple steatosis can advance to non-alcoholic. Steatohepatitis, NASH, fat plus inflammation, and hepatocyte ballooning injury, which in turn can progress to fibrosis, cirrhosis, and hepatocellular carcinoma. NASH is now a leading cause of cirrhosis and a rising indication for liver transplant. Management centers on the metabolic drivers, WEIDLOS. exercise and control of diabetes and lipids. Distinguished from alcoholic steatohepatitis, AST-ALT, history, and other causes. The insulin resistance-driven fatty liver with ALT-AST that can progress to NASH and cirrhosis is NAFLD. Which statement about taste and olfaction is correct? A physiologist studies the chemical senses, taste and smell. Read the command, which taste olfaction statement is correct. Taste X EN by X XX 5 tastes. Olfaction CNX bypasses thalamus, regenerates from basal cells. The chemical senses are taste and smell. Taste, gustation, detects 5 basic qualities: sweet, sour, salty, bitter, and umami, via taste receptor cells and taste buds. The afferent nerves are 3 cranial nerves, CN7 facial, via chorda tympani for the anterior 2/3 of the tongue, CN9 glossopharyngeal for the posterior 1/3, and CNX vagus for the epiglottis pharynx. These relay through the brainstem, solitary nucleus, and thalamus to the gustatory cortex. The correct answer is A. Olfaction smell is distinctive. Olfactory receptor neurons in the nasal epithelium CN send axons through the cribriform plate to the olfactory bulb and then to the olfactory piriform cortex. 2. High-yield features. 1. Olfaction is the only sensory modality that reaches the cortex, whites out first relaying through the thalamus. For primary processing, it has direct limbic connections, explaining smell's strong link to memory emotion. And 2. Olfactory receptor neurons are among the FEW neurons that regenerate throughout life. From basal stem cells, the CNZ YGOI taste pathways, and the thalamus, bypassing, regenerating CNI olfactory system is correct. Which statement is correct? A patient with known inflammatory bowel disease is evaluated. This question targets the extraintestinal manifestations and complications that distinguish Crohn's disease from ulcerative colitis. Read the command, which IBD extraintestinal complication statement is correct. Crohn, transmural, skip fistulas, strictus granulomas, UC mucosal continuous colon, increased colorectal CA, toxic megacolon, PSC, shared extraintestinal. This revisits inflammatory bowel disease from the complications extraintestinal angle. CRO, Eschen disease, is transmural full thickness. Inflammation with skip lesions can occur anywhere from mouth to anus, often terminal ileum, and shows non-caseating granulomas. Its transmural nature produces the characteristic complications: fistulas, escherichias, obstruction, abscesses, and perianal disease, plus malabsorption and gallstones from biosorption, and calcium oxalate kidney stones. The correct answer is C. Ulcerative colitis is limited to the mucosae submucosa, is continuous from the rectum, and involves the colon only. Its key complications: a markedly increased risk of colorectal cancer, so surveillance colonoscopy, toxic megacolon, dangerous dilation, and a strong association with primary sclerosing cholangitis PSC with PNK. Both diseases share extraintestinal manifestations: seronegative arthritis, anterior uveitis episcleritis, erythema, nodosum, pyoderma gangrenosum, and aphthous ulcers. The Crohn fistulas has strictures versus UC cancer megacolon PSC contrast, with shared extraintestinal features is correct. Which statement is correct? A patient on an ACE inhibitor for heart failure develops a dry cough, another develops angioedema, a third, with renal artery stenosis, has a rise in creatinine. This question targets ACE inhibitor, side effects, and cautions. Read the command, which ACE inhibitor side effect statement is correct. Decreased NII plus increased bradykinin leads to cough, angioedema, hyperkalemia, AKI, and bilateral renal artery stenosis, teratogenic, first-line HF-HT, and diabetic nephropathy. This revisits ACE inhibitors from the side effect caution angle. ACE inhibitors, the prill drugs, block angiotensin-converting enzyme, which has 2 consequences: LES angiotensin II, vasodilation, less aldosterone, and more bradykinin because ACE normally degrades it. The bradykinin accumulation drives the two classic side effects, the persistent DRY-COUH and, less commonly but more dangerously, angioedema, swelling of lips, face, airway. The correct answer is D. The other high-yield effects. Hyperkalemia, less aldosterone, leads to less K+ excretion, caution with K-sparing diuretics. Renal failure, a CU kidney injury in bilateral renal artery stenosis. These kidneys depend on angiotensin Di-mediated efferent arteriolar constriction to maintain GFR, so blocking it drops the GFR and raises creatinine dicaine. Diureferent arteriolar constriction to maintain GFR, so blocking it drops the GFR and raises creat. Any injury in bilateral renal. And teratogenicity, ACE inhibitors, ARBs cause fetal renal malformations, so they are contraindicated in pregnancy. Despite these, they are first line and reduce mortality in hair failure, treat hypertension, and are renoprotective in diabetic nephropathy, reduce proteinuria. The bradykinin-mediated cough angioedema with hyperkalemia, renal artery stenosis risk, and teratogenicity is the correct ACE inhibitor. Which virus is responsible, the family, and the complications? An unvaccinated child develops fever and bilateral parotid gland swelling, puffy cheeks. A teenage boy with the same illness develops testicular pain and swelling orchitis. Read the command. Virus, family, complications, parotitis, plus orchitis, unvaccinated, mumps, paramyxovirus, orchitis meningitis, pancreatitis, MMR. This is mumps, caused by the mumps virus. A paramyxovirus envelops single-stranded negative sense RNA, like measles, RSV, and parainfluenza. It is spread by respiratory droplets. The hallmark is paroditis. Inflammation and swelling of one or both parotitized salivary glands, giving the classic puffy cheek, swollen jaw appearance with fever and pain on chewing. The correct answer is E. The complications are high yield, remembered as the gland and organ inflammations. Orchitis, testicular swellings, pain, especially in postpubertal males, usually unilateral, can rarely impair fertility. Aseptic meningitis encephalitis, pancreatitis, and oophouritis. Mumps is now rare in vaccinated populations because it is prevented by the MMR, measles, mumps, rubella, VACCE, a live attenuated vaccine, and outbreaks occur in undervaccinated groups. The paramyxovirus causing parotitis with orchitis, meningitis, and pancreatitis prevented by MMR is mumps. What is the immunodeficiency and the molecular defect? A boy has recurrent cold, non-inflamed staphylococcal skin, ABSC sepsis, and pneumonias. A coarse characteristic facial appearance, retained primary teeth, eczema, and bone fractures. Labs show markedly elevated itchy E and eosinophilia. The defect impairs a signaling protein needed for H17 cells. Read the command immunodeficiency and defect. Cold staph abscesses plus high, IgE plus, eosinophilia plus coarse facies plus retained teeth. Jobe hyper IgE syndrome. Stat 3, TH7. This is Job syndrome, hyper IgE syndrome, an autosomal dominant immunodeficiency caused by a defect in state 3. State 3 signaling is required for the differentiation of Th17 cells, which normally recruit neutrophils to sites of infection. Without adequate Th17 function, neutrophil recruitment is impaired, so infections fail to mount a normal inflammatory response. The correct answer is A. The features are memorably captured by phated, coarse facies, broad nose, prominent forehead, cold non-inflamed staphylococcal, ABSC SEs, retained primary teeth, 2 rows of teeth, increased IgE markedly elevated, and dermatologic problems, severe ECZ-ema. The hallmark cold, ABCZ-ema. The hallmark cold, ABC-EZ, that lack the usual warmth, redness, inflammation because neutrophils aren't recruited. Patients also have recurrent P pneumonias forming pneumatoceles, eosinophilia, and bone connective tissue problems, fractures, scoliosis, hyperextensibility, contrast CGD, extensibility, contrast CGD, Higashi LYST, Chediak Higashi LYST, giant granules, and Wiscott. Aldrich Wastidopenia, low igma high iggy eggy. The Stat 3 S-Sima thrombocytopenia, low IgM high Egi. The Stat 3 SN17 defect with cold abscesses and very high IgE is Job syndrome. Block 33 is done. Let's review the 5 biggest traps from this block. Trap 1. Keep the cardiomyopathy straight. Dilated is systolic dysfunction with a low ejection fraction. Hypertrophic and restrictive are both diastolic dysfunction. Restrictive has stiff, infiltrated walls with a normal ejection fraction, classically from amyloid. Trap 2. Crescentic, rapidly progressive glomerulonephritis is classified by immunofluorescence. Linear means anti-GBM, good pasture. Granular lumpy bumpy means immune complex. Haushy immune means anti-A associated vasculitis. Trap 3. The pentose phosphate pathway makes NADPH, not ATP. NADPH maintains reduced glutathione in red cells, powers biosynthesis, and fuels the neutrophil respiratory burst. Lose G6PD and red cells hemolyze under oxidative stress. Trap 4. Water under the bridge. The ureter runs beneath the uterine artery near the cervix, so is the structure at risk when the uterine artery is ligated during a hysterectomy, the classic iatrogenic ureter injury. Trap 5. The ACE inhibitor, dry cough and angioedema come from bradykinin buildup, not low angiotensin. Remember hyperkalemia, the danger in bilateral renal artery stenosis, and that they're teratogenic? Avoid in pregnancy. 33 blocks, 660 questions, train process, not memorization, StepLogic. Learn how to think, not memorize.